Examination of the eye, nose, and throat for the non-specialist. Let's look at examination of the nose. Is there obvious rhinorrhea? And if so, what is its nature? Does the patient have a plugged nose? The typical hyponasal speech or rhinolalia clausa, or does the patient present with a nasal air leak on talking? As rhinolalia epenta, as noted for example in patients with cleft palate. Is the patient obviously gasping for breath when talking, or does he have dry lips and sit mouth open mouth? So more formal examination of the nose starts with observation of the external nose and facial structures, looking for displacement of the nose and abnormalities of the skin underlying it, such as rhinophima. Rhinophima is due to thickening of the skin of the nose and hypertrophy of the sebaceous glands. Although seen in alcoholism, it is not always due to it. The nature of the nasal discharge should be noted. Anterior rhinoscopy may then be carried out, and in most instances, adequate examination may be carried out simply by lifting the tip of the nose with the thumb whilst inspecting inside the nose using a good light. The handheld horoscope may often be adequate. And after examination of the tip, the anterior part of the nose usually has been carried out for a more detailed intranasal inspection, and this may be performed by using either a tandicum speculum or by utilizing the handheld horoscope with the suitably large oral speculum, which may be introduced into the nostril. So among these points to note on the anterior rhinoscopia, points to note on the anterior rhinoscopia: the position of the septum, any bleeding points, the nature of the nasal mucosa, and the appearance of turbinates. The examination of the pharynx may yield important clues to nasal disease, for example in mucopurulent postnasal discharge from infected nasal sinuses, perhaps even with the secondary pharyngitis. Finally, the nose may be palpated, noting any structural abnormalities and testing also for tenderness over the maxillary sinuses and medially below the supraorbital ridges for frontal tenderness. Gentle percussion similarly may elicit pain.